Hello, Dr. H here, your source of musculoskeletal care, and today we're going to do a video that is long overdue. I've already done one technique video already on high velocity, low amplitude technique. You can see a link to that up here. But while I do use that technique for sure, it's actually not the technique I use the most. So this video is going to dive into the two broad categories of techniques that we use in osteopathic manipulative treatment, or OMT for short. Then we're going to dive even deeper into one particular type of technique, and it just so happens to be the technique that I use the most. So let's talk about that. So as any DO will tell you from their medical school training, we can divide all the techniques that we learn in OMT into two broad categories: direct and indirect. Direct technique is kind of what it sounds like. We pick a structure, it can be anything, a joint, a muscle, a tendon, a ligament, something like that, and we take it where it doesn't want to go. So as just an example, if your shoulder doesn't like to externally rotate, we would then take it into that external rotation, into that restriction. After that, we would do something and try to push it through that restriction. Again, probably the best known direct technique is what we call high velocity, low amplitude technique. Chiropractors sometimes call it an adjustment. In the physical therapy world, it's often known as a manipulation. But that's sort of a popping, cracking thing that people are familiar with. Again, there's a video on this channel explaining the science behind that if you want to dive in deeper. But that's not the only direct technique. There are others as well. We have something called muscle energy technique, and even some types of myofascial release can be very direct. But they're all trying to do the same thing. Take a structure into that restriction and try to get it through that restriction. Indirect technique, on the other hand, is pretty much exactly the opposite. Again, we have a target, a joint, ligament, muscle, something like that, and we actually take it where it wants to go or away from that restriction. We then kind of hold it at that state of ease or that state of relaxation. Again, often doing something, maybe adding what we call an activating force. This can be compression, traction, torsion, something like that, but keeping it in that state of ease. The whole idea behind indirect techniques is a lot of these restrictions that we have come from guarding reflexes from our nervous system. In other words, a structure is in trouble, our body's trying to protect that structure, and in doing so creates a lot of the restrictions that bring patients into my clinic. And so if we can identify the structure that's in trouble and take it into a state of ease or relaxation, holding it there for a little bit, we can create an environment of ease so that the nervous system no longer feels like it needs to have those guarding reflexes, and therefore the guarding reflexes go away. And when those reflexes go away, so do the restrictions. Again, if we want to use the shoulder as an example, if it doesn't like to go into external rotation, we might take it into internal rotation where it does like to go. And once we've held it there for a bit, or again, added some kind of activating force, the nervous system calms down and removes whatever guarding reflexes was keeping it from going into external rotation. So the best analogy I've come up to sort of distinguish these two broad categories of techniques is your junk drawer at home, right? We all have one. Usually it's in the kitchen. It's a drawer where everything goes that didn't have a place otherwise. It just fills up with more and more junk, and then invariably one day you go to open it and something causes it to jam. A ruler pops up, a pencil, something like that. The equivalent of a direct technique would be kind of taking a good step back and giving that drawer a hard yank, hoping to kind of get past whatever was holding it up. An example of an indirect technique would be to just close the drawer again, do some kind of activating force, so maybe jiggle it around a little bit, hope that that restriction drops down, and then the drawer is able to open. The goal of both techniques is the same: get the drawer open. It's just the way they go about them is very different. One of the most common questions we get, for example, from medical students is, how do you know when to use one versus when to use others? And that could probably be a video in and of itself, but the short answer is it really just depends on the patient and their body, the structure you're trying to get to or trying to address, and the preference of the physician. There are, for example, patients that I've treated where if direct techniques aren't done, they feel inadequately treated, Whereas on the other hand, I have had some patients where if direct techniques are done, their body will actually flare. The problem will get worse. And so being able to know what bodies respond to what and what tissues respond to what, and sometimes just personal preferences is kind of all part of the process. But there's no really firm, hard rule of, oh, this problem requires a direct approach and this problem requires an indirect approach. It's a pretty multifactorial thing. And to be honest, most of us who specialize in musculoskeletal medicine and hands-on work use a combination of both. But one of the many reasons that I wanted to make this video and put this out there is because indirect technique can seem a little counterintuitive. And sometimes patients often say, it doesn't really feel like you're doing anything. And to be honest with you, they're kind of right. We're not necessarily doing anything. The goal of indirect technique is to put the body into that state of ease. From there, we're relying on the body and the nervous system to kind of do the rest, to kind of calm down and remove those guarding reflexes and those restrictions. So when we do these techniques, it can have a pretty profound effect, right? We're putting the whole body kind of into a state of ease by targeting the structure that we think is the biggest problem. But when we do that, not only would we remove restrictions around that structure, but we very well may remove restrictions elsewhere in the body as well. Technically, with direct techniques, we're doing the same thing, where we're kind of trying to stimulate the nervous system to have a response. But again, that's a different video, and you can watch my HVLA video for more information on that. But at least that one feels a lot more like the doctor or the physician or the hands-on person is actively doing something, whereas indirect technique doesn't. And that's why I want to explain a little bit more in detail what precisely is going on. So with that, let's do a deep dive into one particular type of indirect technique, the technique that I actually use the most nowadays in my clinic. This is a technique called counterstrain. Sometimes the longer version of the name is strain-counterstrain. It's an indirect technique with the goal of kind of putting the body in that state of ease. I wanted to specifically address this technique because I feel like it's something that most of my patients have never experienced before. Again, like I said in the beginning of the video, if you've seen other people for hands-on work, massage therapists, physical therapists, chiropractors, you've probably had some of the same techniques done to you there that I also use in my clinic, but this one seems to be less common outside of the world of OMT. So this technique begins with me checking points on the body that correlate with structures that I want to evaluate further. So what I'll do is I'll usually poke these points on both sides. The reason for this is because sometimes we're poking in areas where it might be a little tender regardless if you have anything wrong or not. However, what I'm looking for is, does one side feel significantly different than the other side? When I say feel different, I mean either to my patient or to me or both. I might poke one side of the body and they say, yeah, that's a little tender, but then when I poke the other, they have, this jump response and say, oh yeah, that's quite a bit different. And sort of along the same lines, if I poke one side and to me it feels nice and relaxed, and I poke the other side and it feels quite a bit different, much more tighter, for example, then I know that side might be the problem. So this is the first part that gets a little confusing. And don't feel bad, this part is even very confusing to medical students who are learning it for the first time in medical school. The point that I'm poking, again, is a reflection of the structures that I'm interested in evaluating. It is not necessarily directly over those structures, and the point itself is not the problem. Okay, I'll say that again. The point might hurt when I poke it, but it is not the problem. It is a reflection of the problem. And so ultimately my goal, when we start talking about how we treat these things, isn't to treat the point itself, it's to treat the underlying structure that point represents. Now, the neurophysiology of why a superficial point might reflect the state of deeper structures gets pretty complicated, and honestly it could probably be a video all unto itself, and probably at some point will be a video all unto itself. But if you were more curious about that neuroanatomy and how all that works, you can look up something called Hilton's Law. So once we found the point that we're interested in, the goal was to put whatever structure we're targeting into that state of ease. For the sake of simplicity, we'll say that structure is a muscle because that's probably the most intuitive structure of the ones we treat. And so the way you put a muscle into a state of ease is you passively shorten it. So you take one end and the other end and you approximate them, you bring them closer together. Notice that I did say passively. This is very important. When you shorten a muscle actively, in other words, when the patient does it, there are reflexes that occur that maintain tightness in that muscle. That's actually a good thing. We want that for how movement works. However, it doesn't allow that muscle to go into that state of ease. Instead, it has to be shortened by somebody else or by something else in order to shorten it in a way that's not activating it. And by doing that, that's when we can put it into a state of ease. I use that point once I'm getting close to feeling like it's in a state of ease. I use that point to determine if I'm doing this successfully or not. I'll repoke the point, and for example, if it was pretty tender for the patient before, it should no longer be as tender, or if it was really tight before, it should no longer be as tight, or so on. Again, I can't emphasize this point enough, and I'll say it a few times in this video. The goal isn't to treat the point I'm pressing on, right? At any junction of moving that patient into a state where I'm targeting that structure, that point might get better, it might feel better, but I don't care yet. The goal isn't to treat the point, it's to treat the structure. So only after I'm already pretty much in a position where I'm getting, in this case, that muscle nice and short and relaxed, will I then recheck the point to see if it's better. If it is, I know I've achieved this state of ease. From here, we kind of just hold that position. This kind of goes back to the idea of, oh, you're not really doing anything. And again, it's kind of true. All I'm doing is creating this environment of ease, this environment of relaxation where the nervous system should no longer feel the need to guard. If the muscle we're treating was a problem before and we've shortened it and put slack in it, now the body no longer feels like it needs to be creating all these restrictions to protect that problem muscle. After a certain period of time, traditionally it's taught as 90 seconds, but I find sometimes it takes a little longer or a little less time. But after a certain period of time, when that muscle's been in that state of ease, we can very gently, carefully, and slowly, and most importantly, passively, bring the patient out of that position that was shortening the muscle. The best analogy I have found to explain this is the seatbelt in your car. If you're driving along and something dashes in front of you and you have to slam on the brake, your seatbelt will lock, right? That's kind of the equivalent situation of the nervous system feeling like it needs to guard. The seatbelt feels like it needs to protect you, just like your nervous system feels like it needs to protect the structure that's in trouble. Once that seatbelt locks, you can tug and tug and tug until you're blue in the face and nothing will happen. It is locked up. And again, it's sort of the same scenario of if you have a really locked muscle, you can stretch and you can pull on it and you can tug on it, and oftentimes nothing's going to happen because the nervous system is continually telling that muscle it needs to stay tight in order to guard or protect something. So what do you do in the case of your seatbelt? You shorten it, you give it slack, you give it ease. By doing that, you're essentially telling that mechanism that the danger is over, that it can relax, it can unlock, and then behave normally again. This is the exact same situation for any of these structures we're targeting. Again, in the case of muscles, shortening that muscle, holding it in that state of ease in that shortened position, letting the nervous system realize there's no danger anymore, removing those restrictions, and then very slowly lengthening it back to where we want it to be. At the end of this video, we'll do a demonstration, and that'll oftentimes help it make more sense. But that is the entire idea of the treatment. So we've put the structure that we're targeting in a state of ease. The tender point decreased, it's no longer tender, it's no longer tight, whatever. We held it there for a bit and then slowly brought the patient out of that position. Once we do that, we can then reinterrogate the point. We can reevaluate that point. If all went well, the things that concerned us about that point prior, the fact that it was tender, the fact that it was tight, boggy, didn't feel like the other side, that should have significantly improved. But this again gets us to this crucial distinction that's so confusing for both patients, for medical students, even for other physicians out there. The goal was never to treat the point. So patients sometimes ask, well, it didn't feel like you were pushing on the point very hard. We're not pushing the point very hard. This isn't a technique where we're trying to do direct inhibition on a muscle. We're trying to poke nice and hard and get it to relax that way. The finger that's on the point is only ever just feeling that tissue, just monitoring it. It's the position, it's treating the structure that's making the point no longer tender or tight or whatever. Just to reemphasize, the goal is not to treat the point, it's to treat the structure. It's the position that you're in that's doing all the work, not the hand that's on the thing that was tender. And making the thing that was tender go away was never necessarily the objective. It's just that if we did adequately treat the structure, which was the objective, the tenderness and tightness in that point should go away. It's more of a metric or a reflection of the structure rather than the target. Okay, so after all of this, the next step might be to find another point, that represents structures that we're trying to target. Of course, this whole treatment process, or any technique that we use, only ever occurs after we've already, taken your history, done a physical exam and evaluation. In other words, if a musculoskeletal physician is treating you, they should already have in their mind what the problem structure is. And so that's why we don't just lay you down and check every single point. That would be incredibly ineffective and frankly bad medicine. We know what structure we're trying to treat, and then we go to the points that reflect those structures and see if they're a problem. Sometimes we're wrong, right? Sometimes we think it's one thing and we poke that point and check that muscle or ligament or joint or what have you, and it's not a problem. Well, then we move on to the next one. Or sometimes we have more than one problem, more than one thing going on, particularly if the issue is chronic, right? There's a lot of compensatory changes and we may not know which one came first and which one came second. So oftentimes we have to treat one thing, and when we do, it gets better, and then we kind of reevaluate, see if anything else is still being held up, and then treat that. All this to say, if you're at the point of needing an evaluation from a musculoskeletal physician, the goal should be a diagnosis of your root cause. It isn't just to treat every little thing we find. Some of them may not be causing any problems at all. The point is to do a thorough evaluation and figuring out what exactly is driving this dysfunction. Because I do often get the question, after I explain how this technique works with patients, they say, well, that's all well and good, but how long will that last? And the answer is it depends. It kind of depends a lot on what caused that issue in the first place. If it was some kind of one-off injury, then maybe just correcting that, giving you a little bit of homework to do, that'll be the end of it. Much more commonly, we're dealing with things like repetitive injuries, overuse issues, postural issues, longer, more chronic issues. And in those cases, it's usually not sufficient to just treat out what restrictions we find. We also need to really address the root problem, right? The postural modifications, ergonomic changes, things like that. That's the benefit of seeing someone who specializes in musculoskeletal medicine. We can help with all of that stuff. So, without further ado, we're going to shift over to the treatment room and demonstrate exactly how this counterstrain technique works. Okay, so now we're going to go ahead and demonstrate this technique of counterstrain. I have my patient here. Just for the sake of demonstration, we're going to pick which muscle we're going to target. Again, I already would have done some kind of evaluation based on her history, physical exam, and would have given me an idea of what structure was in trouble, and I would then go and evaluate that particular point that reflects that structure. But again, just for the sake of demonstration, I was going to pick a muscle that I think a lot of people are familiar with, probably for not great reasons, and that's the psoas, your main hip flexor. And so the point that reflects the psoas is located kind of in this abdominal pelvic area here. And so what I would do is I would get on either side, checking both points, and I would say, this is A and this is B. And oftentimes what I'm looking for is a patient to say, oh yeah, B, for example, was much more tender than A. And again, I'm feeling the tissue as well. So I'm feeling the tissue behind A and B. And oftentimes that alone can kind of tell me which one's the problem. Just for the sake of the camera and again demonstration, we'll say that B over here on the patient's left side is the one that's a problem. Okay, so now that we found this point, we're going to have to put this patient into a position of ease. So we're treating the hip flexor. That means we're going to have to flex the hip. This can be a little bit tricky because, as I said earlier, this has to be done entirely passively. We don't want the patient contracting this muscle during this process. So ultimately, we're going to flex both hips up, but we're going to do this one at a time to try to keep things as passive as possible, particularly on the side that we're targeting here, this left side. I'm going to start by just bringing this leg here up and then lifting that onto my knee so that my knee here gives it support and she doesn't have to activate this muscle. I'll then bring the other one up as well. And then I'm going to just kind of flex both hips, feeling with my thumb to see when that tissue gets nice and relaxed. The psoas is not just a hip flexor, it's also an external rotator of the hip. And so what I'm going to do is also externally rotate the hip using the feet like this. Now again, I don't care about what this point is doing up until now. If it got better at any point in the interim there, that's irrelevant to what we're trying to do. Only now that I know I have this muscle in a shortened position do I recheck the point. And so I might poke it again, see how it feels, and ask the patient how it feels. And maybe they say it feels a lot better than it did, but it's still a little tender. At that stage, what we do is we make little micro adjustments. We try to get this tissue to its maximal point of ease. And so I might play around a little with the hip flexion. And again, these movements are all very small. I could add a little compression, a little traction, whatever. Once I feel like it's completely relaxed, and when I can poke it and the patient says, oh yeah, all that tenderness that was there before is gone, that's when we start the however long process of holding it here. Again, traditionally it's 90 seconds. That's usually a pretty good amount of time. That said, sometimes it takes a little longer. Sometimes it could take less time. Okay, we'll pretend 90 seconds have passed. The next tricky part is getting these legs back down in a way that's completely passive. Again, if she were to activate this hip flexor, this psoas muscle, on the way down, it would undo a lot of the work we did. So we go very slowly and very gently, and I always coach the patient to stay as relaxed as you can and let me do all the work. So we'll kind of let the hips come up. Again, you can see how slow this is. And what I'm going to do is give these knees a lot of good support and bring the feet down first so that they can just slide off the table like this. And at no point did she have to contract that hip flexor on the way down. Notice my finger never left that point, and so I can reassess it at this juncture and say, how's that now? If everything went the way it's supposed to, it should feel better to me, it should feel better to the patient, and that restriction that they were having should now be gone. Like I said in the earlier part of the video, after this, I could maybe reassess the pelvis, check something else, see if there's another muscle that's in trouble, check its corresponding point, and treat it if I found it. But that's kind of how the whole treatment process would go. Okay, so that's it for this technique video. Again, I thought this video was very important because while I don't exclusively use this technique, it is by and large the one that I use the most, and it's also kind of one of the weirder, less intuitive versions of OMT that you may experience. So let me know if you have any questions, if you want me to make videos on other OMT techniques. I do have a plan to make a video sometime soon, hopefully, getting real nerdy about musculoskeletal diagnosis as a whole. But until then, keep moving.